My committee members include my doctoral chair, who is Holly Stick, my second reader, who is Dr. Maria Schnell, and my community member, Dr. Holly Frankfurt, who is a doctor of osteopathy, who is the medical director of the Demand Project. That is a small organization in Tulsa, Oklahoma, who helps victims of human trafficking. Some key abbreviations that may help you understand my presentation better include RCT, which is Randomized Controlled Trial, USDHHS, which is the U.S. Department of Health and Human Services, and Human Trafficking, which is HT. I have this nice little photo here to let you know how important human trafficking is to myself. Some background and significance. I'm going to hit on the purpose, aims, and background of my project. So the purpose is to develop a human trafficking clinical practice guideline to assist in identification of those victims. The aim is implementation of an evidence-based practice relating to human trafficking screening tools and development of a human trafficking clinical practice guideline in the outpatient setting and encouragement of care of further human trafficking victims. So approximately 1.1 million individuals in the United States are estimated to be affected by human trafficking yearly. And approximately 88% of these victims report they have sought care in a healthcare institution at some point during their victimization. Some additional background information. This clinical practice guideline was created from the U.S. Department of Health and Human Services screening tool for victims of human trafficking. Additional modifications were based on myself and stakeholder feedback, and the screening tool will include questions for both adults and children, so it will be applicable to patients in all settings. A little bit of background about myself. I have had a care for human trafficking since about 2018. I used to be a forensic nurse examiner and a sexual assault nurse examiner, and went to a human trafficking gala or a dinner, which just created a love for human trafficking for myself. So that is what inspired this project, and it is pretty much my life's work. The literature review, I first used Ovid Synthesis, which gave us 5 relevant publications. And then the second search strategy I used was Maryville Library's Discovery Engine, which yielded 6 relevant publications. So I had 11 publications total. My search parameters included articles published between 2015 and 2025, included randomized controlled trials, cohort studies, case-controlled studies, cross-sectional studies, review articles, and guidelines. And some keywords I included were trafficking, human trafficking, exploitation, screening tools, sex trafficking, and labor trafficking. Strengths of my literature review included informed consent. Every screening tool that was given to these patients included a informed consent, so the patients knew what they were getting into. Beneficence to the patient, and an adequate sample size studied in the literature reviews that I saw. Some weaknesses noted were observer bias related to victims of human trafficking, such as a patient or another healthcare provider thinking that women are the only ones affected by human trafficking, or thinking that very little victims are affected by child sex trafficking, or that labor trafficking isn't as prevalent as it is. Here in Oklahoma, we have a very large sex trafficking, labor trafficking highway that goes through Route 44 or Interstate 44 that goes right through Tulsa and right through Oklahoma City. Also, another weakness noted was self-reported or patient-reported outcomes, because human trafficking victims do not generally self-identify for fear of repercussions or fear that their victimizer is currently with them and that they will get caught. So some themes noted in my literature review were the need for a screening tool, which I am creating, a lack of awareness and indicators of human trafficking, a need for trauma-informed care. A little bit about trauma-informed care: it decreases re-traumatization of individuals and shifts the thinking of healthcare providers to look through the lens of trauma history, allowing staff to identify with what happened to the patient, what the patient experienced, rather than what is wrong with the patient. And then holistic care for victims and survivors. Victims and survivors need care just as somebody who's being victimized needs just as much care as somebody who has been out of victimization and years out of victimization and in survivorship. They still need the same amount of care. On to my theoretical framework. I chose Kolkaba's comfort theory. Kolkaba defines comfort as the fulfillment of basic human needs for ease or relief from stressful healthcare situations. The basic assumption of this theory is that individuals have complex responses to complex stimuli, and comfort is the desired outcome. And individuals endeavor to meet those basic comfort needs. So dimension 1 consists of 3 depositions: relief from needs, ease regarding efficient performance, and transcendence, in which the individual feels that ordinary potential is increased, where they feel like they can do things that they would not normally do. And then dimension 2 relates to the circumstances in which comfort occurs. So physical, psychospiritual, social, and environmental circumstances. By creating a screening tool with questions related to a patient's current victimization, the staff can address the current victim's basic needs, such as their environment, and begin addressing the patient's comfort needs. And then after those screening tool questions are completed, additional areas of comfort, such as physical and psychospiritual, social, and environmental, can be defined and addressed. So dimension 1 was met by the screening tool by the creation of the screening tool with questions related to current victimization. Dimension 2 was met by a referral pathway for victims that was created for a positive screening. As these victims are taken care of by the screening tool and things that we have implemented with the screening tool, they will hopefully feel relief and comfort. Now on to the methods and design. This clinical practice guideline gives us steps on administering the tool and the next steps needed after a positive screening. No human subjects were studied, so they will not be included in this study at all. There was no current screening tool in place at the Scholarly Project site. The agreed-to instrument was chosen to assess the clinical practice guideline, as it assesses the scientific rigor and transparency in clinical practice guideline development. And analysis will establish the strengths and weaknesses of the screening tool and the recommended improvements to be made. The data was aggregated from the screening tool by extracting answers into an Excel spreadsheet. Attached is the planning phase to the result phase of my project. On to this sample. Again, there were no human participants studied, so they will not be included. There were nursing experts and stakeholders chosen from my personal and professional contacts for this study. The inclusion criteria for these reviewers was an age of greater than 18 years old, experience in forensic nursing care, or experience in psychiatric mental health care, and or experience with dealing with victims of human trafficking. Participation was completely voluntary, and I have attached the pie chart that shows the professional designations of the reviewers that I included, which included a licensed clinical social worker, a psychiatric mental health care nurse practitioner, an executive director / EMT, and a doctor of osteopathy who was also my committee member. Data analysis. Ordinal measurement was used to analyze data from instructions included on the agreed to instrument. A score of 1 on a 7-point scale indicated a reviewer strongly disagreed with a statement, and conversely, a score of 7 indicated they strongly agreed with a statement. And then a sum of these totals was combined to gain the overall domain score from all the reviewers and the scaled domain score. The domain scores will be used to establish strengths and weaknesses of the clinical practice guideline. And the agreed to tool does not establish an official score for acceptance of a clinical practice guideline, however, states that high quality clinical practice guidelines have a scaled domain score of greater than 70%. So the author, myself, chose a scaled domain score of greater than 70% for acceptance of the clinical practice guideline. Here are the domains in which the reviewers and stakeholders had to review the clinical practice guideline that was created. And the agreed tool was present for all of the reviewers during and throughout the review process, as well as the clinical practice guideline. For the results, my scaled domain scoring showed my lowest scaled domain score at 56% and my highest scaled domain score at 73%. Further revisions needed included editorial independence, rigor of development, stakeholder involvement, and scope and purpose. A statement of scope and purpose was needed. A mention of stakeholder involvement was also needed. Notation of evidence supporting the guideline and of any risks to the patient. Methods of formulation for recommendations and updates to the guideline is needed, and notation of competing interests and views of the funding body not influencing the guideline was also needed. After that, all reviewers recommended the clinical practice guideline for practice. The variability of this project showed a homogeneous data set, and the standard deviation for that data set was 4.04. Attached is this table, which shows the maximum and minimum possible domain scores, as well as the domain total and the scaled domain scores. And below that, attached is the agreed to equation for obtaining those said domain scores. On to limitations. A lack of human trafficking protocol at the scholarly project site was noted to be a limitation. There was no quality improvement department at the scholarly project site. No previous quality improvement projects were completed or in progress at the scholarly project site. There were some time constraints during the duration of data collection, which I will touch on further here in just a second. And there was no established clinical practice guideline for human trafficking at the site and in the reading as well in the outpatient setting. So back to time constraints and duration of data collection, I feel that this could have been extended if I personally started to create the clinical practice guideline and then present it to stakeholders rather than have the stakeholders create the clinical practice guideline with myself. If I would have created that clinical practice guideline myself, handed it to the stakeholders for edits, and then had them review it, I think I may have had a different scholarly project outcome. However, that is a post-implementation insight. Discussion. So again, this project's not a study, and the doctoral project's findings will not include post-implementation data. There was a positive culture shift noted in the stakeholders during this project as they asked additional questions about human trafficking and what policies would need to be in place post-implementation or pre-implementation rather. All stakeholders recommended the clinical practice guideline for use in practice either fully or with modifications, as I stated before. The results of this project support the use of the clinical practice guideline. and the results of this project can be compared with previous studies. There has been no current screening tool validated specifically for use in the outpatient setting, and there needs to be ongoing training related to signs of human trafficking among vulnerable populations. The scholarly project site that I completed my project at does take care of vulnerable populations, has a large LGBTQIA population, takes care of Medicare and homeless populations, so there were no diversity, equity, inclusion concerns related to post-implementation insights either. Trauma-informed care is also crucial in caring for victims of human trafficking. Some implications for practice I categorized into 3 subcategories. 1 for the nonprofit organization, 2 for workflow changes, and 3 for administrative. For the nonprofit organization, they are willing to study the clinical practice guideline to further establish sensitivity and specificity. They plan to establish and gather the data needed through giving my clinical practice guideline to their current victims of human trafficking as they house them, to see if any further revisions are needed or if this is sensitive or specific enough to be used in practice. Workflow changes include training and an increased workload for staff and a possible workflow change for staff. Administrative implications for practice include policy changes related to the clinical practice guideline, additional administrative work and possible cost related to possible EHR implementation after the clinical practice guideline is implemented, and additional training related to the screening tool should a positive screening occur. In conclusion, this project is relevant and scalable to other settings. It is applicable to both children and adults. There is further research planned to ensure sensitivity and specificity of this project, as it will be given to human trafficking victims that are already known human trafficking victims. The screening tool will be given to all individuals regardless of diversity, equity, and inclusion concerns, and these results support the implementation of the project with necessary modifications made. Attached are my references that I used in this presentation. And thank you all for listening.